Almost from the onset of the coronavirus epidemic in the United States, New York has been described as the epicenter of the outbreak, and Elmhurst Hospital in Queens, the epicenter of the epicenter.
Obviously, Elmhurst Hospital in Queens is right now the epicenter within the epicenter.
Elmhurst Hospital is the epicenter of the epicenter.
And Elmhurst Hospital is really at the center of this crisis here in the city and in the country, with doctors desperately trying to keep up with the growing number of patients as supplies dwindle.
And you see the black body bags? You say, what's in there? It's Elmhurst Hospital? Must be supplies. It's not supplies, it's people.
Also from the beginning of the crisis, ventilators were described as essential life-saving equipment, initially in short supply.
You picked the 26,000 people who are going to die because you only sent 400 ventilators.
I knew that every person who needed a ventilator and didn't get one would die.
But why does New York, and Elmhurst in particular, appear to have been hit so much harder than other places in the United States? And were ventilators ever the right approach to treating COVID-19, especially once we realized that 60 to 90% of those vented do not survive? The experience and observations of nurse Erin Olszewski seem to offer some answers to these pressing questions, while simultaneously providing frontline information about a number of other hot-button topics, including the disproportionate number of COVID deaths among Americans of color, the distortion surrounding do not resuscitate orders, the disregard for personal protective equipment standards, and the clustering of COVID positive with COVID negative patients, which she witnessed again and again, and the tremendous amount of nosocomial or hospital-acquired infections that resulted. Perhaps most urgently of all, she speaks of the therapies and protocols employed in her home state that did work. Erin was brought from Florida by a service funded by the Federal Emergency Management Agency. She spent almost a month at Elmhurst. What she saw there compelled her to become a reporter and whistleblower alongside her already extensive nursing duties. She made recordings, posted warnings on social media, and spoke through proxies about the nightmare conditions she witnessed.
Okay, so if you look close, I'm in my patient's chart. I am pulling up like their laboratory results. So if you look here, you'll see COVID-19 bioreference lab. Here are the test results. As you can see, 5/1/2020 at 17:16, not detected. They test for a second time, 5/4/2020 at 17:59, not detected. So both of those are negative. Scroll up to the top. This is my patient. They are on a vent and they are being called COVID-19 confirmed. Droplet in contact and eye protection.
So this person is droplet and eye COVID confirmed. Positive A, click, not detected. No resulting lab available. Oh, pretty good.
While Erin was using her hidden camera to document another chart showing a patient with negative test results who nonetheless was labeled COVID confirmed, another travel nurse entered the room. They began to discuss what Erin was seeing.
If it says bioreference, that means here. It's done here.
So not detected here, but so it's presumptive. Now, they're all...
They are detected. They're saying it's positive. Not detected.
But it's not detected.
Say, what does that mean?
So
you said that they were vented immediately upon being brought in, is that?
Yeah, so the thing is they're coming in with difficulty breathing, and a lot of these patients are really coming in with anxiety because they're scared. And when I was back home, I was working in the ED out in the tents, and most people that were coming through with like symptoms of just, anxiety, or they're worried and they're breathing fast, and then they get all nervous. So this is how the people are like coming in. Now, I'm not saying that some of them, don't have COVID. Like there are people that come in and they really do need help, not to the extent of a vent, but they need help. But these other people, like this person who wasn't COVID multiple times, you know, and a lot of them are on either Medicaid or Medicare. They're poor. They're from, you know, a lower class. We're at a public hospital. They need the funding. So take them. They take them. And they tell them pretty much that if they don't get on a vent, then they're probably not going to survive. But the reality is, if they get on that vent, the likelihood of them walking out the hospital is slim to none.
And can I ask you, what like PEEP are they on, and is that being mandated or specified what the pressure is on the vent?
Here's the thing with this. So you don't have actual doctors that know critical care, ICU doctors on these floors. There's a dentist, and there are residents with these. So residents are essentially students, and they have no idea what they're doing. Like, I had to police, actually today I had to police a resident because he wrote an order for me to run Versed, which is a medicine that you have to be very careful with because it can kill someone, at like quadruple the speed of what you should be running it at the dose. And had I not known that, then I would have easily killed the patient. And it would have been okay under their COVID standards. So everything is kind of a wash. Nobody's held accountable for anything. And these people that are at events are essentially being like, these residents are like practicing their skills on them. So they're practicing central lines, they're practicing like invasive procedures that are really unnecessary.
What percentage of the people that are in there would you say actually have tested positive for COVID?
Half. Probably half.
But everyone is being treated as though...
The entire hospital is COVID. So half the hospital is not COVID, but they're on COVID floors.
So let me just ask you about nosocomial infection. So you're saying they're putting non-COVID or COVID rule out with definite COVID patients?
Yes.
So I was only wondering, because like I was looking at like all the patient rooms, and like this patient is in with like a non-COVID. I don't understand why they're doing that.
I know. There's 4 patients in a row here
Yeah.
on COVID. And this is supposed to be the COVID place.
Yeah.
Because 7th floor, they've shut it down.
That's
and
right.
cleaned it.
I'm confused.
And then they're going to have non-COVIDs there.
Yeah.
This is going to be the only COVID, so they shouldn't put any non-COVIDs here.
Well, that's what they've been doing.
They're banking on the fact that they'll get it because they're already immunocompromised. So and they'll put them in the same room. So there's double rooms. So you have a COVID with a non-COVID. They don't even care. We have enough rooms where they can be separated now because it's not as busy as it was, 4 weeks ago. But they don't care. They're just putting them together. I have that right now happening.
And like the guy over in...
I had 2 26 that were 2 negatives.
And they end up positive. Like the guy over in 29, I had him upstairs because I was on CCU before it.
Yeah.
And he came in with a stroke.
I know, that's what 26-1 was, a stroke.
And
Nothing
no
to do with
COVID.
Nothing to
And
do
now
with-
he's got COVID and he's on a vent.
Well, because we gave it to him here.
We have in the United States, and we've had it for a while, a rapid test. It's 45 minutes. Do you have COVID, don't you? They're not doing the rapid test here.
They're not?
No.
Okay.
At
Elmhurst, you've never seen them?
Nope, they don't do it. It's too expensive. They do 5-day. It's like 5 to 7 day turnaround. In the meantime, they admit them onto COVID units. So non-COVIDs, the rule-outs are going to COVID units and waiting for the results. Even though we have a rapid result, which is 45 minutes, and they're not doing it. No.
How come you guys don't do the rapid test here?
Because city place, it exists. It's just they don't have access to it. There's only limited supply, so if you have deep pockets, you get it first.
Oh, so money.
Most times it's money about everything, yes.
That's sad.
It's a reality.
I compare this hospital to a third world country. I've been in a third world country hospital in Iraq. The Iraq hospital is better than this one, and that says a lot. I've been there. I've been in both hospitals, and this is in the United States, and this hospital is treating low income, mostly, people, and it almost makes me feel like they think these people are disposable, and they're not. They're people. You know, people are not disposable. You know, especially the ones that are struggling day in and day out, the hard workers, you know, like trying to reach that American dream, and they're not given a chance because they're brought to this place where nobody cares. So in the hospital that I'm in right now, it's all COVID at this point. Every single floor is COVID, and they made it that way, obviously, for a reason, in my opinion. But a person cannot come to the floor unless they have a COVID diagnosis.
Is the reason, did they not want to cross-contaminate? Would that be the legitimate reason why you would create an all-COVID floor?
Here's why I will say no to that, is because they're admitting people for, quote, COVID rule out. So this guy was probably admitted COVID rule out, tested him, they saw that it came back negative. They probably already did something where they needed to now call him COVID, in the hopes that if they're putting him on a COVID floor and there's nurses going room to room to room, he will get it, and then they'll be back to when he does pass that he did have COVID.
Yeah, I mean, that's quite, that's quite a charge. I mean, what makes you think they really want them to get COVID? Because
money. Money. I think it's at least $29,000 per patient, and then you have to think you are also charging supplies and more supplies and more supplies. That's just like a bonus money.
But but the residents aren't getting that, right? I mean, why?
Oh, that's the thing. And I actually I've went at it with a lot of residents already, and they're order followers. So there was a resident, and I have this on tape. I taped it because it was just so disgusting to me. A 37-year-old, which is my age, was not a DNR. He's a full code. His family in-depth discussed with the doctors that they want us to do everything they can to save him. He came in talking. He was very terrified. He was just like, totally alert, knew what was going on, and they convinced him to be on a vent. Now he's dead. But the doctor said when I got into shift that if he codes, that we are not to resuscitate or try to save him. And we flipped.
So we're supposed to... He's not DNR, but we're treating it as DNR?
Basically.
Does his family know?
His family knows the situation. I think they called them and they told them. They were trying to do a school attending consent for DNR. Okay. All day he spent like in the 80s saturating. It was this one on the forehead didn't work. This one worked, and it came down. When I changed it, I was like, oh shoot, it's 90. Yeah. So they started playing around with the
Oh shoot, it's 90.
Because he's still on pressure.
He changed the pulse ox from his head to his finger, and he's like, oh, it's 90.
I had to put a sign up last week, don't touch my...
He's fine.
Don't touch it. Nothing.
So what was that?
So that was, we were just getting on shift because we were starting the night shift at 7. And that was the nurse from the day shift saying pretty much we shouldn't code him if he's going to code. And then I turned my glasses on.
Why are we being told not to code him, essentially? That's what he said.
I mean, because I'm going to tell you right now, if he bottoms out, I'm jumping on his chest. Period. Point blank. It's going to happen.
Okay.
Because until that status is changed in the computer, that's what I'm obligated to do under my nursing license.
Right. I mean,
because you guys aren't going to back me up and protect me.
Well, Elmhurst does have a policy given, like a COVID policy, given the scarcity of dialysis and blood.
It can be a chem code, it can be whatever.
That it's not, there's not it's a difference. Normally the standard is whatever the family says, like we just do. So if they would say code him for 5 years, like we just do that until they die. It's a little bit different now because of the new policy in place with Dr. put in place, which is that you don't need full family like you can just tell someone that it's medically futile and that we're not willing to just pour blood and resources into something that would be impossible to get back.
Right.
But look, it's brutal. He's 37. I mean, it's brutal.
Well,
So
they
they
tried.
said, well, our higher-ups have agreed and our attendings agree that this is futile care at this point. He is not going to make it. I said, he doesn't have an epi drip going. He doesn't have anything to sustain going. And I said, and who decided this? And I said, can you put a comfort care order in then? No, we can't do that. Can you put a DNR order in? No, we can't do that. I said, so what's our plan?
Do we have modified?
She goes, well, he's dying. And I'm like, I understand that, but there needs to be an order indicating that either I'm doing compressions or I'm not doing compressions.
Well, I can say that we can all be in agreement that we will do it. I will definitely.
Because I'm going to jump on him.
Yeah.
So will I. I'll go right with you. I don't care. That's what we're here for. I'm not playing like these
until they
stupid
change
games.
his status that he is a DNR, and they can do it through physician consent if they've talked to the family.
Yeah.
But until they change it, and I see it, he's a full code to me.
We know when someone we're close. We'll pull the code card up and be ready. You know, we're ready. I had the epi ready. That's one of the first things we do. And she wouldn't let me give it. So this was that woman, and the entire time, and this was over his body, his alive body, and we're arguing, and she's laughing. She was smirking, and how this man died was the nurses arguing with the doctors over him as he was dying, and she's smirking the entire time. It was probably one of the worst experiences in my entire life. But all I can think about is that at least he knows that we were fighting for him when he died. You know. But this was my conversation after what happened, and the guy I told you about earlier that had pulled his tube out, he was up at that point. Like, he was on the same floor. He had pulled he was the one that they wanted to sedate. So at that point, he was doing better where he could walk. This doctor had put a diaper on him and told him to poop in his pants. So after the code, I went to go check on him, and he goes, I have poop in my pants. I'm like, why do you have poop in your pants? And he said that because the doctor told him that he has to do that, and I just lost it. It was her.
This is wrong. It is straight up it is wrong. And I am 37 years old. I have been in a hospital since I've been 16. Military hospitals that well.
What aspect of it was wrong to you? I agree that there were parts of it that were wrong too. So.
Calling a patient a DNR when there's no order for it, and telling us, like straight up telling us, you're not doing anything. That's wrong. If that was my brother or my father or anybody, I would be furious. And I guarantee you, if I called his family right now and told them what happened, they would be furious too.
I flipped. We were all crying. There's a lot of nurses that know that this is wrong, but they're afraid to like say anything publicly.
She said, when I was talking to her, she said, we're not always given the orders. It comes from the top down. And I was thinking, that's the exact problem with everything. Where's it coming from? What's the purpose? Are you guys really trying to kill everybody like everybody thinks?
Within our unit, it was a big fight, and ultimately the kid died with us over his body arguing about this. You almost feel like you are literally living in the Twilight Zone, and you feel like you're the only sane one in a bunch of insane people. And it's scary because these are the people that others are trusting to take care of them, and they're really doing the opposite. I'm to the point where I'm afraid that I'm going to start thinking that this is normal. I don't want to ever get to that point because they think that, like the people I work with that are local nurses and doctors don't see anything wrong with this.
Really? I mean, they don't,
No.
do they see Was it just like kind of a hard past few months? Is it, or
this has been like this, and from what I hear, like I mean, there are good nurses that work there too. Like, I have made good friends with a lot of the nurses that do work there. There's good people, but they're outnumbered.
So what happens? People come in like this 37-year-old, and what was he complaining of, or what was going on?
Respiratory distress. He didn't have COVID either. He did not have COVID.
It was like the day before intubation, he was fine on the rebreather.
And then they intubated, and then he got a pneumo, and then they put in a PEP tube, and then it's been shipped.
And now he's 37 years old and dead.
Because that's what I'm seeing, like all these negative tests, and they're putting them on these vents. Hopeful that they'll get it. They're being put on these COVID floor. It's murder. It straight up is. It is setting these people up for failure based on money.
But Medicaid is who pays out, or who's paying this bonus of $29,000?
I believe it's Medicaid, Medicare. It's government money. I don't know exactly where it's coming from, but I know that it is. But I know the orders are coming from the above, someone above, and everybody says that it's someone higher up. I'm like, good, call them. Like during that DNR when they're telling us, or the full code when they're telling us not to, do CPR. I'm like, all right, call your higher ups then. Let's talk about. And they wouldn't, because they're all scared. Everybody's scared, and everybody's scared to stick up for themselves. And I've called a lot of doctors unethical to their face, and they deserve it.
What killed him? Did the vent kill him?
Yeah. Oh yes. They're so sedated. He had probably 8 or 9 drips. It's all sedation. It's all sedation and paralytics. So you are asleep. It is essentially like you're under, you're in surgery, when they put you under like that for a good month straight. There's no way you can recover from something like that. You'll be brain dead if you do.
So can you list some of the drugs that they're put on the drips?
Yeah, there's propofol, fentanyl, Nimbex, Versed. Gosh, hang on, I have a list. I think it lists from. This is one of my patients was on this. Just one patient. So Nimbex 100 milligrams, Precedex 400 milligrams, fentanyl 2,500 micrograms, heparin 25,000 units, Versed 50 milligrams, Levophed 16,000, Neo 50 milligrams, propofol 10 milligrams, vasopressin 100 units. This is one person, and all these drips are running at the same time into them.
So in the case of this 37-year-old, he comes in complaining of some respiratory distress. Did he have low blood oxygen?
Totally healthy guy, and he was satting that's the oxygen saturations, and like 88, 89.
So a little low.
I mean, yeah, but people do that. You and I probably do that, where we're not monitoring our oxygen, all day long.
But he felt shortness of breath, so he came in.
Yes.
And what was the next step? What would have happened next?
He went to a step-down unit, among other.
What does that mean? Sorry.
It's just a unit where people aren't quite on the vent yet, and I say on the vent yet because I should call it a step-up unit to the vent. But
so was he? What's the phrase you used? COVID
rule out.
COVID rule out.
So that's how they admit everyone to the floor that doesn't have a positive COVID immediately.
Okay, so he's put in the step-down unit, which is a euphemism for step-up unit.
Yeah. And
what happens to him there? What's going on there?
Oxygen. I wasn't in this unit. My friend was.
So just normal oxygen, nasal?
No, they'll do like a high pressure.
So what does that mean exactly? What does it look like?
Pretty much like a forced. It almost looks like a big thick nasal cannula, and you put it in your nose and it forces the pressure in. It can almost be like it's still causing your lungs to expand, right? But what they really need to be doing is like the non-rebreather mask, but they just skip it usually. They go right to the high pressure, so their lungs are already,
So, and tell us what a non-rebreather mask is.
So that's just, there's a bag that is on the end of these masks. It's not forcing air down your lungs.
Okay.
It's more natural.
Okay.
And you can put 100% oxygen. That's what people need.
Okay, so and that really is not the protocol. It's not the protocol to start people on that.
I mean, it should be, but it's not how they're doing it now.
I mean, in your prior experience dealing with people with low saturation, would that be what you would do?
Oh yeah, that's what we were doing, in my hometown.
And were you having better outcomes there?
Yeah, we didn't have this because we treated them properly.
What would you say the kind of the case fatality rate was?
None. 0. Yeah, by me, 0.
And what is the likelihood of coming out of the hospital you're in?
I'll tell you that the unit that I've been on, the only person that survived, ironically, is a guy who pulled his own tube out. Yeah.
So he woke up enough to be able to do that?
Yeah. He wanted it out. He should have never been on in the first place. That's a whole nother story.
So let's just keep going with this 37-year-old. So he's on the step-down unit, and he's being given semi-pressurized oxygen. It's not a rebreather mask. And then what happens to him?
They'll start treating them with medications, that will...
And are they checking his saturation at this all the time? Does he have...
Yeah, he's on a continuous pulse ox, but the minute that he desats, like they'll see like, oh no, he's at 87 now, or oh look at this, oh he's gonna need more help, and then they go tell them that they need more help even if they don't. It's ultimately what it comes down to is like people being just lazy and wanting to treat. They just want to treat.
Is there any incentive to the? Okay, you're saying that the incentive for the residents is kind of experimental almost.
They're order followers,
and they're
like they want to please. That's what they're doing. They want to please, and like the protocol of that hospital is to treat.
To treat invasively according to this protocol. And do we know where this protocol originates? I mean, because obviously the governor was talking about getting vents. Everyone was talking about getting vents. So this seems like this comes from very high up.
Yeah, I mean, if you're gonna tell somebody, the entire world essentially, especially the entire United States, when they're like, we need the vents, like if you tell people something enough, they're going to start believing it. So that's exactly what happened.
Tell me why Cuomo immediately thought 2 months ago that they'd need 30,000 vents. How do you just come up with a number?
Cuomo's an idiot too.
Well, Medicare's paying them that money for people.
29,000 a vent.
So our 37-year-old, what happens to him next? So they say, okay, it looks like he's at 87, he needs more, and so is that the point at which they would intubate him?
Yeah, that's when he stepped up. So he stepped up to the ICU.
He steps up to the ICU.
For more care, right? They start off with a little bit of like muscle relaxer, and he's woozy. You have to remember there's no family with these patients, so they're alone and in hospital by themselves during a pandemic that they're terrified of already. That's likely what brought him in the first place. He's totally healthy otherwise. And then you have doctors. They think they're doctors, but they're resident. Technically, they're doctors with absolutely zero experience. I've had to teach residents several nursing skills. Telling them that they have a choice, they could likely die from this, or they can be saved by, getting a tube and that will help them breathe. They don't call it ventilator. We can give you a little help breathing. And that's it. Then they get the sedation and they go to sleep, and that's it. They don't wake up. He's in a body bag.
And so the drugs have a deleterious effect on the body, on the brain, but is there something about the pressurization of the lungs that is also causing harm?
Yeah, they're having the PEEP, that's the pressure in his lungs, which is causing this barotrauma of people. It's blowing people's lungs out. So when that happens, what do you got to do? Turn it up more. You just keep.
Because the membrane expands, so that you need, in order to fill them and deflate them, you need more pressure.
Yeah, you're gonna have to max it. I mean, we have a guy right now who's maxed out on everything. There's nothing more you can do. So then what? You just wait for them to die? I mean, there's nothing you can do.
Can you tell us what PEEP levels are they started on?
It depends. They're always usually, well, they'll start, there's some good ones. I can't say everybody's bad.
Mm-hmm.
There are some good doctors that'll start them out on 5, which people should be at about 5. But that doctor goes home and the next doctor comes on shift and cranks it up. Then what? It's hard to go back down.
And what oxygen level are they put on?
It depends. I mean, as they start to deteriorate more and more, then the oxygen obviously is going up. There's a guy right now, I have him on 100%, and I'll have to come in and, give him a little bit more rush of 2 minutes of even more oxygen just to keep his stats up. I mean, that's what happens to people.
In your home state where you were treating people, what would the protocol be?
I mean, it varied upon each individual, but we definitely would never go immediately to, you're going to need a vent.
You didn't feel pressure to diagnose people? There wasn't a pressure to diagnose people COVID?
Not at all. No. We're not a public hospital, too. That makes a huge difference. What I'm seeing is it's the public hospitals, and this is like in other states, too. If you look at all the hospitals, most of them are public that are needing money. But our hospital would just treat them based on the individuals, and they were using the hydroxychloroquine and the zinc and, that protocol, for sure.
At your hospital?
Oh, yeah.
And that seemed to work?
Yeah. We didn't have anybody that died. I think there was one patient that was admitted and went home like the day later. And I'm in a pretty big city, so.
And were these people who were elderly with comorbidities who were having good outcomes?
Yeah, actually one guy the one guy that was admitted came from a nursing home. And he was obese, like severely obese.
And he
yeah,
left.
He's fine.
He left after a day?
I think it was like a night, maybe 2 nights max, but.
And what do you remember what he was treated with?
I didn't have him on the floor, but I can imagine he was treated with the protocol that we would prescribe the patients before they left the emergency room.
Which was?
With the hydroxychloroquine, zinc.
Why do you think that's been demonized so much?
Because it's working, and then people wouldn't need vents. There are proven treatments that have passed 3 trials in Asia through Dr. Chang. He's a U.S. board certified physician. Is this extremely high dose IV vitamin C? He's successfully treating people with that. And what that's doing is it's giving your body, essentially your lungs, the power, the antioxidant power to kick it out, while you can be getting IV antibiotics to be treating this and getting rid of it. But they don't want to have anything to do with it here. What they want to do is just throw them on a vent and sedate them. So the guy that pulled out his tube is really unique, because I saw him from the minute he got to our unit, and I didn't agree with him coming to the ICU. But he was admitted with hyperglycemia, which is high blood glucose, at 700. So it's pretty high. I learned later that it was high because they were treating him with a lot of different psych drugs, and that increases it was the treatment that got him to the 700. And when you have a blood glucose that high, you're automatically going to have altered mental status. So now they called him crazy. Okay, so he's admitted to the ICU, and everyone's like, well, why is he here? Because he was acting, he was acting out. He didn't know where he was confused. And I went in there, and he wasn't my patient, but we help each other. And I went in there and I tried to talk to him and calm him down. Like, hey, he's just like, I just want to get out of here. I want to get out of here. He has soft restraints on, so they restrain everybody. We have soft restraints on all of our patients, the majority of them, for sure. Which I think is crazy, but it goes with the territory, because everybody's really lazy and it's easier to just treat them with drugs or tie them to their beds. So he was tied up. Obviously, what is that going to do? It's going to make, you're tied up in a hospital, you don't have any family. What do you think? You're going to freak out. So he was. And his oxygen was sitting at 88, 87. Doctor comes in, I should say fellow comes in, and she says that if you can't get your breathing under control, we're going to have to put a tube in you to help you with that. And I go, what? I'm like, he doesn't need a tube down his throat. Like, he doesn't need a vent. She goes, well, yeah, he's desatting. And I said, no, like, absolutely not. He does not need that. We need to get his blood sugar under control, and he will be fine, and maybe not tied to this bed. And she goes, yeah, we'll talk about it. We'll just monitor him. And I was working night shift. This was probably around 6 a.m. At 6:45, we had a code down the hall. The code passed. Had to do all that. Got out of there. I come back for shift, and guess what? The guy has been on a vent. I was so upset. They did it, I guess the nurses that took over said they did it literally as I left.
So I come back in the morning, he's on a vent. And like, you have to be f***ing kidding me. He did not need a vent.
They waited for you to leave.
They did.
We literally, that was the morning we coded 28 for 3 minutes. That we no sooner took the vent out of that room, cleaned it, and put it in here.
Yeah.
And tubed him.
Yeah, they took his vent after he died and put it on him.
So they waited until I left, because they know how I feel about this stuff.
Same thing with bed 9. They didn't need to intubate him. He was progressing. I don't think that I don't know what happened after. We tried BiPAP, and then they brought him here, and I thought, well, cross my fingers and see.
And no one survives. He did. He was the only one that I've had.
That's what happened with him.
But he pulled his tube out, and so he has a chance again.
Oh, he did?
He extubated himself.
Oh, he did? I didn't know that. I thought he was extubated.
Do you think that the reason you never got a COVID wave in Florida was because of any of this lockdown? Or, I mean, I know you're not an epidemiologist, but what do you think was going on?
I live right by, and that was like worldwide news. People were at the beach. I was one of those people at the beach with my kids. Sunlight, it's vitamin D, it's good for your immunity. Fresh air, salt water, all these things are really good for anyone's immune system. You have to be out. Mental health, we were all at the beach.
And so people, if there was a lot of transmission going on...
Wouldn't you think our hospitals would be flooded? They were not. I'm right at the beach. I'm right by the beach. Didn't happen.
Because the lockdowns happened after all that, and... It
was spring break. The beaches were packed. I mean, there's people from all over the world. Tons of New Yorkers live by us.
If there was something you would want to tell everyone in the country and everywhere else, one last thing, what would it be?
I would say this is the one thing that I've had a struggle with, is if someone like me or anybody is trying to tell you something that might go against your beliefs, just listen, really just take it in instead of jumping on it, like think on it for a night or a day and like look into this stuff, because, and ask people about it. Like, not every nurse is going to have the same experience. A med-surg nurse that's on the floor, even in my own hospital, has not had the same experience as the ICU nurses have. And once I sit down and explain it to them, it all makes sense. They're like, yeah, that makes sense. We see that because we'll send them to your, you know, so just think about it, you know, and be respectful, and like we don't want to, no one wants to put themselves in a situation like this, you know, and it's really hard. And this is the reason that a lot more people and nurses are afraid, because people are so quick to, you know, defend something that they don't really understand.
What are you referring to in particular? Like this protocol or what?
Like I referred to earlier, if you tell people like something enough over and over, like the media was telling people, you know, vents, 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 vents. And then you say, as a nurse, no vents, you know, it's not a good, it's not a good position to be in, because I'm going against what the government says. But does the government really have everybody's best interest in mind? You know, are they thinking of, you know, the 57-year-old grandma that, you know, didn't have to die, or the 37-year-old that was totally fine when he walked into the emergency room and he didn't have to die? You know, are they thinking about, you know, maybe the guy that had a drug problem that didn't have to be vented, but he saved his own life? I don't have anything to gain. I have everything to lose by sharing what I'm sharing right now, you know, but so be it, you know. I think it's important that these families get closure, and I hope that someday they'll be able to, you know, hold them accountable for what they did.
A few days after we recorded this interview, Erin began to feel that her time at Elmhurst was drawing to a close. Her vocal questioning of hospital procedure and her efforts to get the word out on social media were getting noticed. She made this recording on what ended up being her last day at the hospital.
I've been taking care of a patient for like a week right now, and this is my and I called him. And he's been doing great. He had a trach put in and he's been doing great. He's been talking and like, or communicating with me. He's telling me, like, laughing at my jokes, and talked to his kids on FaceTime a couple days ago. And I told him that, I told his kids that he was doing fine. And he was. And today I was giving him, and they came in and they told me that I need to leave the room and I have to give report to somebody else. They took me from that unit and they put me in the emergency room, and they don't need me there, but they put me there, and I'm not even there like 20 minutes. I'm not even there 20 minutes and I hear a code being called in my room that I was just left. And it's him. And he was fine. He was fine. I don't understand. Nothing makes sense. Like, why would they take me out of his room and put me in the ED? And then not 20 minutes later, he's dead. It doesn't make sense. Like, did they kill him? He was my one patient that was gonna live. He shouldn't have died. I don't know what they did to him. Something's not right.